ground rules tonight, we're on the record. We are live streaming the event on our website. We are also live blogging the event, and the hashtag is Stanford ACA. Any tweets to that hashtag will be pulled or may be pulled into the live blog. We have two student moderators who I'm going to introduce right now. They're going to introduce our panelists and then kick off questioning. Then we'll open up a round of questioning to the journalism students and then to anyone in the room. So our two moderators are Haley Goldbach. Haley is this year's Stanford NBC News Health Reporting Fellow, and Rivali Reddy, a senior communication major with a minor in biology, and Rivali has been doing an independent study with me this quarter on the Affordable Care Act. Take it away.
Great. So we're going to start by introducing our panelists to you one by one, and then they're going to open with some opening remarks before Haley and I ask the first round of questions. So our first panelist is Dr. Donald Barr. He's a teaching professor of pediatrics in the Stanford School of Medicine.
Ms. Srija Srinivasan. She's the Director of Strategic Operations.
Panelist is Professor Jay Bhattacharya, who is an Associate Professor of Medicine. Panelists to please present their brief opening remarks. So Dr. Barr, if you would start.
Thank you. Thank you very much for convening this and for giving me the opportunity to talk to you. And I want to talk to you about the big three. Psychologists talk about the big five, but in health policy for decades, it's been the big three: cost, quality, and access. And when we look at our healthcare system, we have been debating these for many, many years. How do we handle cost, quality, and access? And there's a long history to this. I'd like to read you some of the history of this. The first is a quote: "As a people, we look upon medical care no longer as a luxury which we may buy, but rather as an inherent right. The humblest patient is entitled to the best of medical service," as published by the American College of Surgeons in their journal in 1918. There was a period of time when the American College of Surgeons was arguing strenuously for this right for all Americans. The American Medical Association argued differently. And so then we get to the founding of the United Nations and the Universal Declaration of Human Rights, Article 25, 1948. It said, "Everyone has a right to a standard of living adequate for the health and well-being of himself and of his family, including medical care." That Universal Declaration of Human Rights has been adopted into policy by essentially all developed countries save one. We are that one. It used to be two. South Africa had not enacted that prior to the abolition of apartheid. With apartheid, South Africa wrote a right to health care into their constitution. And then the third quotation, the third quotation, we now have the core principle that everybody should have some basic security when it comes to their health care. And that was President Obama upon signing the Affordable Care Act in 2010, and so is the core principle of a basic security in health care the same as a right. We'll let that go for now. But what I'm going to suggest is that of the big three, cost, quality, and access, there has been most attention over the decades on access. And the Affordable Care Act pays principal attention to increasing access. It does this through two principal ways. One is the Medicaid expansion for those states expanding Medicaid, although when the original Medicaid was passed in 1965 and enacted, it went into law in 1967, only 24 states enacted Medicaid the first year it was there. 5 years later, all states but one, Arizona, had enacted Medicaid. I will predict that we'll see the same expansion of Medicaid within 5 years. The other way is through the access to private and purchase health insurance through the health insurance exchanges or health benefit exchanges. And the combination of the two were projected to increase access to health insurance and to decrease the number of uninsured Americans by 30 to 35 million by the year 2019, 2020 over what it would otherwise have been. But that was the principal goal of the Affordable Care Act. It does address the issue of cost. In fact, it's projected to reduce federal health care costs by a little over $1 trillion over 10 years, largely through reducing Medicare costs through accountable care organizations, number one, and then delegating to this body, the Independent Payment Advisory Board, IPAB, the explicit job of saying, okay, you folks come up with a way to keep Medicare costs in line with GDP growth. And we'll do it. So long as you don't reduce benefits, increase costs, engage in healthcare rationing or other things, but still you can do it. So we'll see. Those are the two ways. But the actual national healthcare costs are actually projected to go up slightly to about 19, I think it's 19.7% of GDP, or 19.9 by the year 2019, 2020. About a half of a GDP point higher than it would have been without the Affordable Care Act. So cost from the federal standpoint may go down very slightly, but cost to the country as the percent of our GDP going to healthcare is actually going to go up even more. So the Affordable Care Act does not really address the issue of cost. The issue of quality, well, we do have the Patient-Centered Outcomes Research Institute, PCORI, whose job it is to develop an expanded set of comparative effectiveness given condition, which works better? Not compared to a placebo, but as President Obama has said, the blue pill and the green pill, they're both effective, but which one works better? Now, of course, they are prohibited by law from considering cost. They may only do which works better, not which one is the better value for the effectiveness for the cost. That they're prohibited. Although the public, once it's given the information on comparative effectiveness, can figure out what the price is, and private insurers and deliverers may indeed use that material, that information. So will the Affordable Care Act work? In terms of access, I think it will. I think that I will predict that the healthcare.gov brouhaha will be gone in 6 to 9 months. And we'll be moving into an expansion that may be somewhat slower than we had predicted, but if you go out to 5 years, we're looking at, I think you will see a substantial expansion of access for many of those would otherwise have been uninsured. Costs? Nope. We're not going to deal with costs right now. So let's all agree to come back in a few years and do this all over again so we can address the issue of cost. And the issue of quality, we'll have to see how the comparative effectiveness works out. So that's my assessment of how the ACA will work.
Thank you so much, Dr. Barr. Mr. Nivasan?
Hi, good evening. Thanks so much for having me. It's a real honor to be in this room. And I'm not in a position to give you comments about whether the law where we live matters, and the way that the law is being implemented varies very significantly depending on your zip code, depending on your state, and depending on where we sit. And even in this very wealthy community, with the riches of Silicon Valley and the intellectual capacity of Stanford and others, we have 81,000 residents in my county that I serve, San Mateo County, 1 in 9 residents without health insurance. And that has been our reality despite the economic boom that occurred in our valley. We expect 47,000 of them to be eligible for new supports through the Affordable Care Act. And we've been working for the past decade on making universal coverage for children a reality in our community, and we've learned some things along the way. Saying everybody qualifies makes a huge difference in actually getting a product to the end consumer. Saying, oh, you might qualify for something if, check one box, go through 7 hoops, come back later to something else, doesn't work so well. So we've had that experience, and now it's the time to have an experience of everyone qualifies, come forward. As Dr. Barr said, the healthcare.gov rollout has received a lot of press, but in many states, California included, there is a gradual ramp up to coverage that's occurring, and we're only 6 weeks into open enrollment having started. Through our work with universal coverage for children, our research also shows that coverage matters. Over a 5-year period, we found a statistically significant reduction in school days missed due to illness, and that's for our kids. We adults that have a lot to offer the economy, and have had to miss work and have our communities suffer from not having our productivity because we were sick, because we couldn't afford to get a pill, we couldn't afford to go to a doctor and had to wait to go to an emergency room. That's a new reality for many people for the first time. We've also found in our work in children's coverage that where this work happens and what is the landscape that supports the capacity for everyone to be at their fullest potential can vary significantly based on political realities, based on provider capacity, based on community partnerships, and those will all come to bear in the ACA implementation, just like any other major social policy change. And I feel fortunate to work in a community that's embraced making the law work for the residents we serve, making the law work for the taxpayers we serve, and trying with the capacities that we have to meet that triple aim of getting people the right care in the right setting at the right time with a long-term view for the public's health and the community's well-being.
Thank you so much. Professor Bhattacharya.
So I think the ACA is it's a some form or another. And and from the quotes that Dr. Barr read you can get a sense of how deep-seated this desire is, how long, and the long history behind this desire. The problems I have with the ACA have fundamentally do with, I think, some 3 broken promises about the law that I'm going to hopefully I'll be able to make clear through the evening. So the first is that it's not universal. That economists estimate about 60 million people lack health insurance at any point in time, some point in time last year. The ACA is projected to cover somewhere between 30 to 35 million, probably fewer given how a number of states have reacted to the law. So it's not universal. There will be still 30 plus million uninsured after the full implementation of the ACA. The second is that, and Dr. Barr mentioned this, it doesn't decrease costs. And in fact, I've done some work where I argue that actually it's going to increase federal expenditures very, very substantially, even while cutting back coverage for the elderly. So it's I think part of the promise of the law was that it would reduce deficits, and that's I think almost certainly to be not true for reasons that again we'll discuss later tonight. And then the third thing, I think, where the law has, I think the law is unstable. It's unstable both economically and politically for related reasons. The law depends very, very critically on a large number of people not acting in their economic best interests, given the incentives created by the law. And bets like that never pay off. And if people do act in their economic best interests, a lot of people will be hurt as a result of the law. So I think which will create political instability for it. So I'm gonna again, hopefully I think I have 3 minutes, so I'll try to make it clear what I mean by those 3 points later, through the course of the evening.
Thank you so much. And with that, Haley and I have a few questions that we're going to ask you, and feel free whoever would like to answer first. So we wanted to start with this idea of, a lot of us in the room are journalists, and we've been spending a lot of time catching up on what the media has been saying about the Affordable Care Act. And a lot of what we've seen is all this talk about, specifically when it comes to numbers, website hits on healthcare.gov or Covered California, these different websites, as well as enrollment numbers. And we were curious what numbers or signals you think we should actually be looking for. Are those apt, figures that will show us whether Obamacare is quote unquote successful, or are there other things that we should be looking at in the scheme of this?
can take one key metric, and this is not for all of the ACA, but for at least one of the key parts, which is the insurance exchanges. So the insurance exchanges, what they are is a marketplace where private insurers can sell insurance plans to the public, and the government rates the plans on the basis of various criteria. And you can presumably go to the website and then shop for which plan you want, and then it'll calculate how much money you're eligible for from the federal government. The key metric to be looking at is not the number of hits, it's not the number of people who sign up. The key metric to look at is what are the premiums in 2015? What are the premiums in 2015? Because one of the key instabilities of the law is that it's premised, at least the working of the exchange is premised on a large number of relatively healthy people signing up and pooling with people like me. Older and gray-haired and so on, but not over 65. I'll tell you, you guys don't. You're all young in the room. If you guys don't want to pool with the likes of me, you guys will lose your shirt. And the problem is that the law, the premiums in the exchanges depend, if they're going to be reasonable, on you guys signing up. Now, there's a couple of reasons I think why it might work to sign up. One is that there are large. If you're single and you make under $45,000, you may qualify for large subsidies from the federal government. So that will lead to some people signing up. And also there's a penalty that you'll have to pay if you don't sign up, which eventually will be about 2.5% of your income. So those two things will push towards signing up. But the key question is, well, people will do it anyways. It actually won't be worthwhile to you to sign up if the premiums are very, very high. And the key metric there is, what do the pools look like? And if you want to look at one number, the number to look at is, what are the premiums in 2015? Because right now, all the insurers are guessing what the pools are going to look like. They don't have any idea. And that's partly causing a lot of the consternation about the law, about the exchanges. We won't know until 2015.
I'd add a couple things. I mean, I don't disagree about the importance of knowing where the cost trend is going, and I agree with both my co-panelists. I think the enrollment numbers matter, and they matter for both a real effect of continuing to attract insurers and providers to participate, to have something of value to offer. And they matter to the marketing of the value proposition of insurance writ large, that people think this is something that can happen. In our children's coverage experiments, it was year 3 before we hit enrollment saturation at around the point that we needed to for a population that wasn't accustomed to having insurance available to them. I think looking at uncompensated care that is still borne by hospitals and the safety net would be an important thing to look at, to tell us, have we changed the system? And I think looking at public health measures for the longer term and the health of the population as a result of having that, whether we have a stable, healthy pool or not, would be good indicators.
Actually, can I add one thing about so I focused my comments on the exchange. Let me talk a little bit about Medicaid, because I think that's a really key. That is it's about 13 to 15 million of the people that are supposed to get insurance are going to be through Medicaid, which is essentially it's health insurance for the poor. And the big change that the ACA made is that Medicaid eligibility in the states that decide to expand it will only be based on whether your income is low enough. So it's like, I think it's 138% of your poverty line or lower if you qualify. I think if you're single, that's like $14,000, $14,500. So if you make less than $14,500 in California per year, you qualify for Medicaid. So I don't disagree with anything you said. I think that those are all really key metrics. But I think the point where the ACA is vulnerable is in terms of how it cares for the poor is the supply of physicians and providers for the poor. The ACA does almost nothing to expand the supply of providers for the poor. For 2 years, in 2013 and 2014, it increased payments to primary care providers for the poor in Medicaid, and then the payments are going to drop back down to the old levels. And if you talk to any hospital executive in the area anywhere, they'll tell you that they lose money on Medicaid patients. That's not going to change in the wake of the ACA. So the key question, the key metric to look at in whether it actually is serving the poor properly is, how long does it take to get a doctor visit? How long do you wait? And in fact, by expanding coverage for the poor through Medicaid, it may actually be hurting the existing poor, who will now have a harder time finding a doctor than they previously had.
So I would agree that the thing to look at is how many people are enrolled as of, and I would say April 1st, 2014 is a important one, because that's the enrollment goes through March, actually, through the websites. Professor Bhattacharya is certainly accurate that you have to be concerned about the issue of if those who enroll are skewed towards older smokers, and also in certain high-cost areas. You'd be so amazed at just how much cost of care for a person with a given health status will vary from geographic area to geographic area. Well, the Affordable Care Act does allow the premiums that the insurance companies charge within the exchange to vary on those factors. I think there's a fourth factor too, but it's your smoking status, your age, and where you live will affect your premium, and people who are over 50 and are smokers will have a much higher premium. That their age will be actually 4 times.
3 to 1. 3 to 1.
It's 3 to 1, 3 times the premium of the youngest enrollees. And then you can add additional for smoking history and high-cost geography, and so there is a way for the insurance companies to adjust for that. But it still is a real factor. But for someone who makes $40,000 a year and works for a restaurant, this is a manager we're talking about. It's a small restaurant, and the restaurant doesn't provide health insurance. Particularly if you're thinking about starting a family and you're in your 30s, or you want health insurance, and I can say that because I know some people in this situation, and they will find it very attractive to have this security, where they couldn't really get that by going into the open market unless they had a plan that had a very, very high deductible, where they didn't even kick in. So I think that the adverse selection is a very serious concern, but the pricing policy for the premiums in the exchanges will adjust for that somewhat. The Medicaid issue is a secondary issue, and I'd like to see the number of Medicaid, because it does add an entire new category, which is people who are poor and don't happen to have either young kids in the house, be elderly, or be disabled. Because if you are poor and do not have young kids in the house, are not elderly and not disabled, you do not qualify for Medicaid under the Medicaid law, but now you do. And those adults don't cost that much historically. The average cost per enrollee of the non-elderly, non-disabled through Medicaid is a few $1,000s a year. And that's not, most of the Medicaid cost goes to the elderly, the disabled, and long-term care costs. So the burden on the state of having their share of these will be relatively small. That's good, but the fact that these folks who previously had nothing are now going to have coverage, and they're going to be looking for a provider. Fortunately, there's going to be 16,000 new public health service physicians through the National Health Service Corps working in primary care. At least there'll be money for 16,000. Whether you folks, when you get into medical school, choose a primary care specialty and choose to work in an underserved community for 2 to 4 years to help pay for your medical school, I think that we will find that the National Health Service Corps option is going to prove very attractive to lots and lots of young physicians. And the expansion of the federally qualified health centers, we're going to actually get, in the same way that veterans go to one healthcare system, and it's very good quality and very good cost effectiveness, and non-veterans go to the private system, we're going to have another system for the poor, analogous to the veterans system for the VA system for the veterans. And if you're on Medi-Cal or Medicare, you simply aren't going to look for the private market system to get a provider because the doctors aren't going to want you. You're going to be looking for a nonprofit community provider to provide your care. And I think that will be, over time, a very valuable resource.
Okay, so before we open up to the audience, I just wanted to ask another question. So I'm interested in expanding a bit more about how the law might affect providers. So Professor Bhattacharya's comment sort of addressed the stress on an already problematic healthcare system, but you also alluded to the law's promise to experiment with alternative ways of paying doctors. You mentioned ACOs, which are accountable care organizations, and there's also bundled payments. So there are some strides towards changing the system toward a value-based care system instead of paying for each procedure. So all in all, how do you think it's going to affect the way the healthcare is done?
It really depends on how it's implemented. And actually, the ACOs are an interesting idea. So let me just expand a little bit and explain about what those are. So the ACOs, the idea is that instead of paying providers for each thing that they do for you, which creates incentives to do many, many things for you, instead we'll pay providers to care for you as care for you as a person. And if they have to spend a lot on you, then that partly that comes out of provider budgets instead of out of Medicare budgets. So and the idea is that if you can efficiently manage a patient over time, then you can get better quality care for the patient, and you can also hopefully save money. Now that's the hope. The problem has been that when the Medicare has examined, run experiments to try to implement the ACO-like incentives, it's been very difficult to actually get cost savings. So there was a big Medicare demonstration project where they paid to have 8 ACO groups experiment with some of the reforms that people are talking about, and 6 of the 8 were unable to get cost savings, and the 2 that did have cost savings, because the government agreed to pay Medicare, the providers some extra money, part of the savings, the federal government actually ended up spending more money on those 2 as well. So I think it's a really worthwhile thing. I think that there's hope to get actually better quality, but there isn't a very good track record for saving money through ACOs. So what Professor Barr mentioned the IPAB, which is a board that's set up by the law to propose cuts to Medicare. Actually, the board, there's been a lot of political trouble with the law, as you might imagine. It's been very difficult to get that board set up. In fact, President Obama hasn't actually appointed anyone to the board as of now. But in that absence, there still have to be, there's still a plan to cut Medicare to help pay, for, at least in part, for the law. And it's interesting, if you look at the most recent Medicare trustees report, the Richard Foster, who is the head actuary at CMS and Medicare, the agency that runs Medicare, has a very, very interesting note in the back of it where he talks about how Medicare actually is planning to implement the cuts. And what he says is that, and this should be an eye-opener for any provider that's out there that takes care of Medicare patients, what the plan is to cut payments to non-physician providers. So that includes hospitals, home health agencies, skilled nursing facilities, basically any non-physician provider. The plan is to cut payment rates to below Medicaid levels. The plan effectively, as far as non-physician providers goes, is to turn Medicare into Medicaid in the long run. Now, whether that's politically viable in the long run is not clear. In fact, Richard Foster argues it's not politically viable. But if we don't make those cuts, then what that means is that essentially we're adding over between a 10-year period from 2015 to 2025 about $3 trillion to the federal budget, none of which is financed, except for these Medicare cuts and some taxes.
And don't forget about the doc fix, which has nothing to do directly with the Affordable Care Act, and all the Affordable Care Act numbers assume that completely independent of the Affordable Care Act, the Medicare payment to physicians under Part B fee-for-service system will be reduced by 27% January 1st, 2014. That's the law. The law says that. And Medicare providers, physicians who are saying, you're going to cut, you already pay me less than the insurers pay me. and you're going to cut that by 27% to below Medicaid rates, and you think I'm going to still see Medicare patients? You're crazy. Now, I'm not sure lots of specialists can continue to do that, but the doc fix, i.e. Congress, has been dealing with this law since 2003. And they've said every year, oh man, we can't cut our friends the doctors. Okay, we won't cut them this year, we'll cut them next year. And we'll pay for the short-term cost, and next year we'll do it. And we have done that every year. That's not the Affordable Care Act. That is going to require Congress and the American public to deal with the issue of the fee-for-service payment system, in which every time you do something, I'm going to pay you for that. If you do it twice, I'll pay you twice. Isn't a sustainable system for a medical care system. And the state of Massachusetts will tell you that, because with the Massachusetts health plan, they have figured out that it's going to bust the Massachusetts state bank unless and their proposal is to remove fee-for-service payment within the state of Massachusetts and shift to a prospective, either bundled or capitated payment, as the only way to make the Massachusetts health plan viable. Well, I'm going to suggest that the doc fix, the sustainable growth rate, and longer term issues Professor Bhattacharya raises about the payment under the Affordable Care Act, and the fact that there are all of us moving into Medicare soon, and Medicare is paid 75% out of general tax revenues, and I don't know where the money is going to come from. We're going to have to change the culture of practice, but that doesn't happen overnight. That takes years to do, and so the accountable care organizations will eventually become the norm, but they're not going to work very well at the beginning until the fundamental culture of care changes.
I think that the major problem is that, take Kaiser. I mean, many of you may have experienced insurance through Kaiser. It's fantastic. A lot of studies have documented it's really, really good insurance. And it works really well in the culture of practice that work in California. But attempts to transplant Kaiser to places where they don't have the kind of sort of provider environments like California have failed. It's very, very difficult to change that kind of culture of practice, as Professor Barr says, in any short period of time. I think the idea that the Affordable Care Act will somehow spur it, that's the hope. That was the hope that behind the law. The people who designed the law envisioned it as saying, okay, let's push medicine in this direction. And the problem is that there's very little evidence that that's actually going to happen.
One thing I would say is that working within a safety net system, these changes for the long term are going to have to be clinician-led. And just as they were in Kaiser in the early years, the cost pressures are there and they're real. None of us can afford the healthcare system that we have unless we wanted to only consume healthcare and not much else. And the pressures are already there on the safety net. We have to live within reduced resources. I wish the Medicaid program were stronger today as well, but it's not, and it's not going to be, and we don't have a future that is, we project that will change. So these changes that are being ushered in by the pilots in the Affordable Care Act, I think, are just a precursor to what other economic and business pressures are going to demand, and we need clinician leadership, physician leadership in organized systems of care to get us to a next evolution.
Let me just pick up on one thing that both of you said, and I think it's worth pointing out that essentially what the ACA system is going to design, the way it's designed, the way it's headed, it's going to create two tiers of healthcare. There's going to be the underfunded public system, where there's going to be elderly people and the poor.
Kind of like now.
Only much worse, because the Medicare is probably overfunded, if anything. So the elderly are going to be lumped into this very, very sort of low payment, underfunded, and then there's going to be the private system. It's going to create two tiers of healthcare in the U.S., where the private system will be this well-funded, really, really rich thing, and the public system is going to be this rump thing where the provider payments are just you have to basically coerce medical students to go into it if you possibly can.
So can you clarify though that whether you're talking by state or the entire country, given that some states require accepting Medicare as a requirement for licensure for physicians?
I mean, they may be the case, but it's really difficult to make if payments in Medicare go down to below Medicare Medicaid levels. a lot of patients, a lot of physicians will opt out. And there'll be pressure on states to change whatever licensure laws they have. Because you can't ask doctors to essentially provide care for less than marginal cost.
So with that, we're going to open the floor to questions from our student journalists, and in about 10 minutes, if anyone from the audience in general has a question. We're going to ask that you please raise your hand. We'll call on you. Please introduce yourself before stating your question. And in order to get as many questions in as possible, if you could perhaps address your question to a specific panelist if possible. So we start right there.
Good evening. My name is Ben Custer, Peninsula Press reporter. Dr. Barr, you mentioned that cost, quality, and access are the big three. In your opinion, how will increased access influence quality, if at all?
Well, the issue of quality has to do with for you work to improve your health. And if I don't really know how much this treatment or that test really improves your health, I can do it and just to cover my bases, but I'm not sure that's really good quality care, nor is it good quality care to withhold that test even when I know it works. What really is going to be the quality care is for me to find out how it works, in whom it works best, and when it's appropriate, and when, even though I could use it, I probably shouldn't, because it's not going to really add much. So if we use the concept of quality of having the optimal return to patient well-being for using this resource, I think that we have the potential of moving to that way of increasing quality. And of course, if someone is blocked from getting provenly effective care because of cost, the access is going to also improve quality. So it's those two ways. Access will be a form to improve quality, but then also having a better sense of what really is an effective treatment will be an enhanced quality.
Hi, my name is Marianne Levine. I'm with the Peninsula Press, and my question is for Ms. Dawson. So from my understanding, in the San Mateo County, a lot of health enrollment counselors are still undergoing the certification process. And I was wondering, looking back, what do you think Covered California could have done differently in terms of getting more health counselors on the ground on October 1st?
Yeah, it's a good question. It's a gargantuan task in California. Their target was 20 to 30,000 boots on the ground. Agents and brokers, issues with the certified enrollment counselors, what's going to be the most bang for the time available. Instead of buck, it was time. In a perfect world, 9 months ago, there would have been more planning for what are the operational steps necessary to train and resource this network of on-the-ground counselors, and it's more complicated in California than most states. Working through other networks, delegating some responsibilities to more localized organizations could have sped up the process. But it's learning as we go, and I think Covered California is learning as we go as well.
Matt Hanson, Peninsula Press. Dr. Bhattacharya, I wanted to ask you if you thought there was a risk of businesses choosing to cancel group health insurance, and if so, is the individual insurance market prepared for an influx of people coming from losing their business?
Yeah, so I have a simulation that I published a few months ago where I found that there are about 37 million people who currently get insurance through their employer that would financially benefit because they would get large subsidies from the federal government on the exchange. Now, not all 37 million will drop coverage. They're going to look and say, look, the penalty, so the law actually has some provisions to deal with this. For instance, there's a $2,000 to $3,000 penalty per employee if you're a large firm. But if you're running a firm with lots of low-income employees, they qualify for the money from the federal government to get insurance on the exchange. They may actually be much financially better off if you drop coverage. And the employer also be better off because they don't have to pay for expensive health insurance coverage. So if in the long run, if all 37 million somehow get dumped on the exchange, it'll be difficult because the federal government hasn't just they're going to have to pay the subsidies and they haven't budgeted for those subsidies. Whether it would help the exchange or not depends on the health status of those employees. Now they're poorer, so they tend to be sicker on average than people the same age. So on average, that would tend to raise premiums on the exchanges, but that's an open question. It's not clear who would end up being dumped. But before I go on, but let me just say one other point about the dumping. I think the key. A lot of people have focused on the employer subsidies, employer incentives, but I think that's really not the key area. The key area is retiree health plans. So, for instance, about 70% of state and local employees, workers have retiree health benefits available, about 17% of private workers have these retiree health benefits available. There is no reason why a private firm should continue to provide retiree health benefits. They're essentially the low-income people that would qualify for large subsidies from the federal government. It would save the employer a bunch of money, and it would save they'd continue to get very, very good, presumably, insurance on the exchange. The only people who would pay for it is taxpayers. And I think there's a big issue that's going to be coming up with retiree health plans for state and local workers, state, county, and local workers, because there's going to be the state is already having difficulty paying for pensions and for retiree health plans. Essentially, by moving the workers onto the exchange, they federalize a lot of the burden. Instead of the state paying for it, the federal government will pay for it through the exchanges. And I think that's a big issue that's likely that hasn't hit the press yet, but is likely to come up, I think, in the coming years.
May I just throw in one issue in terms of the dropping coverage? There's a big unanswered question. If I'm the employer and say that I'm going to figure out it's better for you to go to the exchange, and I drop coverage, am I going to take the $5,000 I was paying for your policy and add it to your wages, or am I going to pocket it? And so I think that's something that really needs to be addressed. I would suggest that an employer that had been providing health insurance, who says, no, please go into the exchange, has the obligation to take the money they were paying for it and add to wages, minus if they have to pay the employer penalty into the exchange.
My name is Amanda. I'm also with the Peninsula Press. I have actually a question for you as a representative of the government. We've been talking a lot about people with smaller incomes, but here in the Peninsula we have like a considerable amount of people that make more than $100,000 a year and are uninsured and should be buying Obamacare to finance the rest of the system. I would just, how is the outreach going to this specific?
That's a good question. So in San Mateo County, of the 81,000 uninsured, there are about 47,000 who have incomes below 400% of federal poverty. So you could do the math of the 34,000 who are above. Those are your example. The outreach and marketing strategy is really a statewide one by Covered California, because in general, local government, that is not our target market. Those are not consumers of safety net services. And there's a wide range of media partners that are being enlisted, ranging from Hollywood and professional athletes to social media to other outlets. The first month of enrollment in Covered California, there were actually more who were signing up for unsubsidized, than subsidized coverage. And I think for many of these folks, they just didn't have a group market to be a part of. It wasn't worth it economically to purchase something. But it's hard to know. It's a new marketing challenge for a government entity, Covered California.
My name is Sarah Hayden, and I'm also with the Peninsula Press. Ms. Srinivasan, I know now in the Peninsula there's a disproportionately large number of people of ethnic minorities who are without health insurance, and there are initiatives with Asian Americans Advancing Justice, and there's different bilingual campaigns going on. What are some of the greatest challenges that you face in reaching those people?
Yeah, it's a really good question. So in San Mateo County, I believe we have 43 primary languages spoken, including the city of Daly City, our largest city that has one of the most ethnically and linguistically diverse. So language is one challenge to overcome, but there's also culture and trust of who people rely on to get information. I think mothers of any ethnicity or language still rank high, especially for young people who we're trying to attract. But reaching those mothers, as well as physicians, doctors, are also a very trusted resource. They're very different care-seeking patterns based on trust of who would I trust to be my healthcare provider. Community health centers that attract a diverse workforce have been good resources to reach those populations. Ethnic media have been good resources to reach those populations. And then there's just the value issue of who's in the plans and who's in the network that is going to be worth purchasing. In San Mateo County, there are 5 plans that are being offered through the exchange. It's notable that the Chinese Community Health Plan that saw a target market of Chinese consumers, decided to bid in our county. Those are a few of the challenges that we're trying to overcome.
This is a question for Drs. Bhattacharya and Barr. You've both spoken about the issues facing country in terms of attracting medical students and current doctors into primary care, like how there's going to eventually be a shortfall of people providing those sorts of services. What sort of fallout are we going to see from that? Because this isn't just an on-paper issue. Eventually, there are going to be not nearly enough doctors for a rapidly expanding population.
I think the big thing is going to be ERs. A lot of people. This happened in Massachusetts actually. It is that when Massachusetts expanded its insurance coverage through its plan in 2006, the ER visits relative to the control states, they actually went up considerably. And it's mainly patients who potentially nominally qualify for Medicaid in Massachusetts, but they can't, or find it difficult to find a usual source of care, and so they end up in the ER. And so I think there's going to be a lot of pressure put on providers of last resort. So some of the providers that Dr. Barr was talking about. Like if you do the math, Dr. Barr mentioned 16,000 more providers for 13 million new people. There's going to be a lot of pressure put on these providers of last resort. Like locally, the Santa Clara Valley Medical Center, for instance, provides for a lot of care for indigent patients. There's going to be a lot of difficulty in making sure that patients continue to get as high quality care as possible when there's such a large number of people knocking on the door, so to speak.
But that there's also going to be an expansion of whom we consider to be a primary care provider. And I'll just tell you about a very interesting study done in the Kaiser Permanente system in Oakland in the 1970s, where they just tried something out, just to try it out. They created a special clinic that had 2 primary care physicians and 6 nurse practitioners. And they took Kaiser members and randomly enrolled them either in this clinic or in the standard primary care clinic. And lo and behold, they actually didn't save much in terms of cost, but the accessibility of care in terms of people getting in for their care was substantially improved, and patient satisfaction with the quality of their primary care was substantially improved by having a clinic with 6 nurse practitioners and 2 physicians, rather than having only physicians as providers. So the idea of the primary care team and nurse practitioners, physician assistants, other types of counselors, social workers or psychologists working as a team will be able also to expand primary care, and people will learn that you don't necessarily have to have someone with an MD after their name to have a primary care provider whom you trust and want to see.
Okay, so I just wanted to ask another follow-up question, because something that's come up more than once is this issue of cost. So 2 of you spoke a little bit about that, and some have framed this as sort of a zero-sum game in which you can't get all of the big 3, as you said, Dr. Barr. You can't have, care that is both accessible, cost-effective, and quality. And we talked about some ways in which the ACA might be trying to at least reduce federal costs, but it sounds like none of you is convinced that that's actually going to be effective in the long term or even in the short term. So Do you think it's a sustainable idea to address this in a stepwise manner? Dr. Barty sort of alluded to this, whereby we first address access and then we talk about cost? Or do you think that it might make a transition to value-based care more difficult?
I think that it's going to make a transition to value-based care more inevitable because there simply isn't another viable option. And it's going to be that I started teaching about the healthcare to Stanford students in the 1990s, and I pointed out that Abraham Lincoln was often misquoted. People thought he was talking about trust, but he actually was talking about medical care. I think what he actually said was, you can treat some of the people all of the time, or you can treat all of the people some of the time, but you just can't treat all the people all the time. And that's the reality of the healthcare system. And by shifting to a system where we're trying to treat all the people, we have been treating some of the people on a regular basis and letting them get all the care they want. But now we're trying to switch to a system that treats all the people. And when you do that, you can't have a system that gives everything to everybody. It simply isn't viable. So we're going to have to shift our mentality to realize that by treating all the people, or nearly all the people, we're going to have to realize we can only do some of the care that's out there and not all of the care. And how do we move into a system where people actually believe that some of the care is good quality care? One of the ways they have to get to believe is that I'm not getting only some of the care so that the shareholders of a for-profit corporation can increase their shareholder return. If that's the case, I won't put up with it. And so we have to be very careful that shareholder return isn't one of the things that drives moving to only some of the care. Rather, it is the idea that this is a social good that has to be distributed more equitably.
Professor Bhattacharya, do you want to comment on that? Because you mentioned earlier that you didn't think that a system is not sustainable if it doesn't act in people's economic best interests. Dr. Barr seems to be saying that perhaps you can use social good as a motivator. Do you think that's...
I think that's, with all due respect, that's a very poor motivator for most people. I think one principle of the system has to be that if someone wants to pay for care for something, that they have the right to pay for care for something. It's not, even countries that have sort of socialized medicine have that principle. Canada, for instance, played with a system where people weren't allowed to use their money for extra care if they wanted, and that was very, very unpopular. So I think that the way let me address the earlier question you gave about the cost, because I think one of the problems I have with the ACA is that if you look at it, it's actually not designed to address costs at all. In fact, politically, the designers of the ACA are very, very scared to address costs at all. Right, so the iPad, for instance, isn't allowed to consider costs when it's deciding whether certain kinds of treatment are going to be covered. The PCORI, which Dr. Barr mentioned, isn't allowed to consider costs at all when it's deciding, when it's making recommendations about what optimal medical care is. The designers of the ACA explicitly went out of their way to make sure that the cost wouldn't enter these decisions. And there's a reason they did that, because it's politically toxic to do that. And so, whether it will be, now, in principle, you might have thought that, okay, we're going to increase access. That's a good part. Everyone likes increased access. And one of the costs of that is we're going to address costs. That's the bad part. If we get that together, if we could get a political coalition around the two together. Instead, we went with was let's just increase access. So now I agree actually with Dr. Barr about one thing. The trends in medical costs can't continue. And so there will be fallout, but the fallout won't be on the private system. Right? The fallout will be on, as I said earlier, there will be two tiers. There will be two-tier medical care. There will be a public system and there will be a public-private system. And the fallout will fall on the people who are in the public system.
Great. And with that, we're going to reopen it to both student journalists as well as any other questions in the audience.
So I'm aware that we're sitting in an audience full of journalists and students and academics, and I think considering the role of the media, how would you all say that people can take both academic studies or government implementation? I think particularly local government implementation, if they're doing a nice job, we don't hear about them at all. So what would you say about how perhaps the press can represent some of these issues in a way that's more accurate or more insightful than some playing off the fears that we hear often. For example, Dr. Bhattacharya, I think some of the things we're saying about Medicare just would be taken and inflamed into this issue of, oh, the seniors are going to have death panels or whatever, right? And so...
No, the issue isn't death panels. The issue is payments to doctors.
Well,
I think one of the problems with the media has been that they've sugarcoated some of the costs. I mean, that's just the reality. If you look at what the actual costs are, they've not been as skeptical as they ought to have been. And so I think part of the shock that you're seeing currently, when people actually have to start paying for the kinds of care, the insurance on the exchanges, as an example, right? The price shock, the fact that there are going to be losers, that was not made clear by the media in the run-up to the law, in the passage after the law, and in the time since the law was passed. And I think that the media has misserved the public by sugarcoating that the fact that there will be losers from the law, and that who those and just explaining, I think the media ought to highlight the winners too. Of course, that's I think as a balanced picture. But I think if you sell, if the media story is, look, we're going to get more coverage, lower costs, lower deficits, better quality. Well, you can't have a free lunch. So a media that sells a free lunch will not be a credible media, and it's doing a disservice to the population. But people see the reality soon enough.
I think we've suffered from having the fact that all of us tune out the media unless there's a juicy fight has fed a media core that has focused on the fights rather than the truth. And I actually have a different problem with the run-up to the law and the implementation of the law, that we had 2 years to inform the American public about what the law means, and we can fault the president for things that he didn't do or Congress for things that they didn't do. But ultimately, this is a political issue that deserves in-depth journalism and in-depth reporting about trade-offs, about consequences, and consequences that we had before the law was passed. Who are these 47 million people that are doing without today? What are the costs they're incurring? Who are the 5 million people who have an individual policy that are being affected today by the letter or the cancellation? And can we put those in scale in a way that human beings understand? Not Stanford students only, but actual, your average reader that can make an informed vote, that can make an informed decision about their taxes, that can make informed decisions about public policy. And I feel like we've had a health media that hasn't dug in deep enough in the places to inform, and instead jumped on covering the problem of the day or the fight of the day.
I'd like to emphasize that there are two aspects of journalism, though, and we've been looking at one aspect. We've been looking at the Robert Pear journalism, which is the New York Times reporter who kind of tries to explain it all on the front page of the New York Times. But I want to emphasize the importance of the Abigail Zuger media, who is the science narrative writer. And to emphasize, she's in the Science Times on Tuesday, and to report the importance and the potential of narrative writing is, I can't emphasize that enough. I think that through narrative of real life people, real life circumstances, and real life situations, it can be much easier to explain some of the complexities to your readers than trying to explain every detail of Article 2, Section 3. But also, I think, and there's a new genre developing, which is physician narrative. Columbia University has a new graduate program in medical narrative. They're hoping physicians or other health providers will come back and get a graduate degree in medical narrative so that they can, through narrative writing, tell the story what it's like from the doctor's side. And I think that the power of narrative can have a lot to offer.
Great. Other questions? Yes, back there.
Hi, I'm Ronald Pia. I'm a senior university counselor here in Stanford's OGC. I have a question for you, Professor Bhattacharya. You started out by saying one of your problems with the ACA is that it's not going to deliver on universality. How much of that would you say is attributable to states, some states choosing not to expand Medicaid? How much of that 20 million or who's not going to be covered are undocumented persons who won't qualify for subsidies? How much is people who will have trouble enrolling even if they do qualify? And then what are the other holes that are not getting to the next level?
Okay, so let me just go slightly backwards through this. The set of people, the question, if you couldn't hear, was that that the population of people who will not be insured after the ACA is fully implemented will consist of different subpopulations. And the question, I think, is what are the relative numbers of those? Now, of course, there's some, you have to do projections, but let me give you some sense of whether CBO thinks. CBO is the Congressional Budget Office, and they do projections of these sorts of numbers. So the CBO currently thinks that about 13 million people will get insurance through Medicaid. The original projection, before all the states started dropping off, was on the order of 25 million. So it's about half of the people who would have gotten coverage through Medicaid won't. But I actually agree with Dr. Barr that the states won't. It's too good a deal. Essentially, the feds are going to pick up about 90% of the dollars there. It's going to be irresistible, right? Because it's a whole lot of money the states will want to see, and I think in the long run, the states that are recalcitrant from expanding it will eventually do that. Again, the principle is if it's in the economic best interest, they'll do it. It's in the economic best interest. The law by design doesn't cover undocumented workers. It doesn't cover, and I think that's the bulk of the 30 million people it won't cover. But in addition to that, there will be many, many people, young people, who look at it and say, well, look, I'd rather just pay the penalty because I don't want to pool with older people. Actually, Dr. Barr mentioned earlier that the premiums are based on age. They are, but the maximum ratio of the oldest person to the youngest person is like 3 to 1. The problem is, on average, the oldest person in one of these plans to the youngest person on average is that ratio really, in terms of medical expenditures, is more on the order of 6 or 7 to 1. And insurance companies won't lower the price they charge to older people. They'll raise the price they charge to younger people. Again, just to stay in business. It won't be a good deal unless you qualify for large federal subsidies, in which case then it's taxpayers that are picking up the bill. So I think a substantial number of people like that will also not have insurance.
And with that, we have time for one more question. So, if someone has one. Yes, go ahead.
My question is about the relationship between increasing access to care and the number of primary care providers. The panel touched on a couple of things that the ACA does to increase the number of primary care providers, but some of you believe that the ACA won't do enough to increase the primary care providers in the U.S., especially in health professional shortage areas. Can you all touch upon this a little bit more as to why you think that the ACA won't do enough to increase the primary care physicians?
It comes down to payments, right? The payment rates are really low for Medicaid, and that's the primary mechanism that the ACA is using to expand coverage for low income. Right? So if the ACA pays rates that equal to roughly what current Medicaid payments are, providers in general lose money on Medicaid patients. You go talk to any health insurance executive or any executive, like you go to Stanford Hospital and ask them if they make money on Medicaid patients, they'll tell you no, they lose money on it. They cross-subsidize. So if you expand the total number of people who are eligible for Medicaid, but you don't change payment rates, you keep them really, really low, you aren't going to get the providers coming online. Now you can have some programs on the side to try to get sort of non-physician providers and so on to come on, but the rates are low there. And essentially what you've done is said, okay, we're not going to pay for you to see a doctor. We're going to pay for you to see a nurse instead. So this is what I mean by two-tier care.
Although the quality of the nurse practitioner care has been shown repeatedly to be every bit as good as the quality of the MD care. Whether the patient believes that is a different question, but the quality of the care has been clearly shown to be equal.
But what about states that don't allow nurses to practice on their own?
There are a number of states, different states have laws in terms of nurses, advanced practice nurses and independent practice. And they need to have some sort of tie-in for backup with a physician. Some states require much more direct, some it's a more indirect. It can be kind of a telecommunication backup. And it tends to be the states that need the primary care rural practitioners that allow more independent advanced practice nurse practice. But there's one other issue, and the medical schools are struggling with this. And the issue is, that I'm not sure we need a lot more dermatologists, cardiologists, and interventional radiologists. What's the best way to choose someone from medical school and have the highest probability that they will choose on their own to be a primary care provider in an underserved community? Is to choose someone from medical school who has grown up in and lived in an underserved low-income community. Statistically, for decades, that person is much more likely to choose to become a primary care provider. So I think that the emphasis on medical education, and then also remember that Medicare pays for nearly all graduate medical education, residents and fellows. And Medicare, if Congress were willing to do that, could redirect that money and say, I'm sorry, we're only paying for so many of these advanced specialists. We're taking the money and we're investing it in primary care. And guess what? If all the cardiology residencies are full, that's it. There's no more cardiology training. You either don't get trained or you train in primary care. And Medicare could use that. They haven't, but it is there.
The ACA does none of this.
No, ACA doesn't touch that.
So this is,
Remember, ACA passed in a very weird way by one vote. So.
Great. And with that, we're going to wrap up our panel. So thank you so much to our panelists. And we're having a reception outside. There are refreshments.